Cancer cells to die either from active self-destruction or from swelling until they literally burst. Tumor growth is stopped and the destroyed cells are discharged by the body in a natural process. As a rule, the 1-hour minimal invasive treatment is repeated 6 times. However, the particles are only injected once, thus making the therapy especially gentle on the patient.
So, in principle, as you have seen, it's the 3 components of the therapy are the nanoparticles, which are made of iron oxide core, and they have a aminosilane shell, which has been specifically developed for interstitial application. So it's extremely the contrast to what we are trying for intravascular application. These particles are rapidly aggregating after injection into the tissue. And then they build up a stable depot, which is really necessary to target the heat sink after this interstitial application. A second component is a nanoplant system, which allows us just to measure the amount of iron oxide in the target region using conventional computer tomography. And then, based on the clear correlation of the magnetic field and the magnetic particles, you have a clear estimation of the power absorption which will occur in the target region. So with an estimate of the average perfusion, you get even a picture what are the temperatures I can expect from the treatment, and then you can steer the magnetic field strength as well as the concentration of the particles, just to have 2 degrees of freedom just to get the right heating, because it's important to in which intention you are using this therapy. Whereas on the market, there are different devices out which are able just to deliver hypothermia, these deep regional hypothermia systems, and well, the most advanced and cost-effective systems on the market, they use electromagnetic fields just to target using interference, heat within the body. But the heating is always dependent on the electrical properties of the tissue. So if the tumor is located within different tissues, then you have a very heterogeneous heating, and it's really difficult to heat up the tumor to the desired temperature. This is best solution here because it's not dependent on the electrical conductivity, the electricity of the tissue, because there's only the correlation between the magnetic particles and the magnetic field. So we have a clear estimate, and there is no thermal limitation. So it's the first system which is able to deliver hypothermia, which is a low temperature range, just to increase the effect of chemotherapy or radiation therapy. But you can also use with the same system just by increasing the magnetic field strength and increasing the magnetic particle concentration in the target region, just to get temperatures which are clearly thermoablation, which means temperatures of 50 degrees, 60 degrees, or 70 degrees centigrade, which are almost only possible with thermoablation systems, which are quite different devices available on the market. So if you're doing as a physician, you are doing in the clinic thermotherapy, hypothermia, or thermoablation, you have to have different systems, but this is a solution all in one here where you can do both. And the third component here is the magnetic field applicator. It's called nanoactivator. It looks like a little bit like a CT scanner or an MRI scanner, but it's quite different because it generates this AC magnetic field, which matches nicely with the particle size distribution, which has been developed as an optimum of power absorption. So you need a minimal amount of particles just to get the heat into the tissue. And as you can see, the positioning of the patient is quite simple, or you don't need a fixation of the patient. So every region of the body can be treated with this method. What we are doing, we have the longest experience with these glioblastoma tumors, where we treated the patients in a combination approach with radiation therapy. This was a phase 2 study for this medical product to get EU regulatory approval. The prostate carcinoma study is also an advanced stage. It's an ongoing phase 2 study. And then the third study, which is also in progress, but in phase 1, is on pancreatic cancer. So this is the overall procedure is quite simple and can be nicely introduced into the normal procedure in the clinic. The patient comes with a recurrent GBM, and then it's a conventional treatment running is done by a DICOM data set using an MRI, and then using very conventional needles and very conventional systems of neuronavigational guided methods, like taking up a biopsy from the glioblastoma. These particles are injected into the tumor, and doing this and the same procedure, a small, very tiny thermometry catheter is introduced. It's a 3 French closed-end catheter, and through this catheter, a thermometry probe is inserted. So we have a verification process of the temperature distribution we obtain by the nanoplant system just by measuring the temperatures during the first course of this treatment. So you have a verification whether the calculated temperatures are really present in the tumor. And then a post-operative CT control is made, so we have this post-implantation analysis because these particle depots are clearly visible in CT. And using the Hounsfield units, you can quantify very precisely how much particles, how much iron is within the target region, and from that we have a clear estimation on the power absorption. And it's combined in this setting here with a conventional radiation treatment, but this was only for the clinical trials. So if the method is now introduced into radio-oncology departments, and especially in neuro-oncology departments, you can also use higher dosages of radiation. But we had here a very minimal dose, radiation dose, just to see what thermotherapy will bring to the patient instead of increasing the dose and increasing side effects coming from radiation therapy. And then we did a follow-up 3 months intervals, and we looked to the outcome of the patients. So it's just that you have a glimpse how it looks like. On the left side you see a typical recurrency of GBMs. It has been resected already, and especially from the tumor edge there come up new tumor cells, which can be clearly seen here in this white edges, white regions. There is recurrent tumor growth. And then in these regions the neurosurgeon injects directly using, as I said, the conventional systems, these particles, and then in the middle picture you can see these white spots within the target region. You can see these are the particles. So in this way they are clearly visible, and when you take this DICOM data set and quantify these Hounsfield units, then you get the concentration. And based on this concentration, power absorption, you get then the calculated temperature distribution, which ranges, which is nicely shown then in all slides you have done with the CT scan. And it's fused with the MRI, with the pre-operative MRI. So you have overall information about the complete head, what are the temperatures we can expect, and it goes from 40 degrees to 50 degrees. This is a sample picture, how it looks like. What we are doing is we use the conventional data set just to make a reconstruction, a 3-dimensional reconstruction. And as you can see, the brown is what we have defined as a tumor region, and within the tumor region, the blue are the distribution of the particles, and then from that we can calculate the temperature distributions, and here is a different view of the same patient. So, and I will come up to more detail about the preclinical and clinical development, and especially on the regulatory aspects and reimbursement in the next session that we have after this talk. Okay, thank you very much so far.